the electrodes there and nothing is outside. That is permanent pacemaker. Okay. Then it's temporary pacemaker, that is transvenous as well. That is, you go through the internal jugular vein like you are passing the CVP. Okay, there's a special type of catheter, we call it a sheath. Okay, you pass that one and you pass the TPM wire through that one. Okay, and you can keep the patient over for a couple of days. That's not permanent. That is transvenous pacing. That's called temporary pacing. PPM is what I have told you. Okay, so definitive is that's permanent pacemaker. Well, for that moment, atropine, if not, apply transvenous and go for apply transcutaneous and go for transvenous pacemaker. Again, bradycardia logarithm, that is important. Okay, bradycardia is if you have less than 60% of 60 beats per minute and you have a sinus rhythm, sinus bradycardia. In a sinus bradycardia, you need not to do anything, okay, until unless it's symptomatic. Even the heart rate is 40. If the patient is not symptomatic, you need not to do anything. You need to observe the patient. But if the patient is symptomatic, by symptomatic I mean if he's having a chest pain, he's cold, he's sweaty, he's having low BP, he's feeling dizzy because cerebral perfusion is now compromised. Okay, that is symptomatic sinus bradycardia. You need to give 0.5 mg of the atropine, and you can repeat that one 3 to 5 minutes, a total dose of 0.3. Okay, if it doesn't work, apply the transcutaneous pads and prepare for the transvenous pacing, that is TPM, temporary pacemaker. Okay, so transcutaneous, you need not to confuse yourself with the transcutaneous pacing. That is just a bridge. Okay, that is just a bridge. The better is go for transvenous pacemaking, and then you go for permanent pacemaker. Because permanent pacemaker, you do it in a cath lab. Okay. Now, if you see at this log, it's like written that, okay, if you have given the atropine, okay, but there is no good response. There is a good response to the atropine, but still, if you have given the atropine, okay, but it's a good response, but patient is at the risk of asystole. Risk of asystole is like Mobitz type 2, complete heart block with wide QRS complex. If the patient has a previous episode of asystole, the ventricle pause is greater than 3, still need to go for pacing. Even if he has responded to the atropine, but if there is a risk of asystole, then go for transvenous pacing. I hope that's clear too. So quickly go to the anti-arrhythmic medications, class 1, 2, 3. One is quinidine and lidocaine using the VTs. Yeah. Okay, the class 2 is metoprolol. That's a beta blocker. Short-acting beta blocker, by the way. The half-life is like 5 to 6 hours. 6 to 7, yeah. And that's given in the AFib as well. We do not give the beta blocker to patients who are having asthma, and do not give the beta blockers to the patient who are having the AV blocks, which we have already read. Okay, particularly in Mobitz type 2 and complete heart block, contraindicated. Class 3 anti-arrhythmics amiodarone. Amiodarone we give in the VT, AFib. Okay, so amiodarone is important. It causes the fibrosis, pulmonary fibrosis, hepatic fibrosis, and causes the hypothyroidism and the hyperthyroidism as well. It can cause both, and the half-life of amiodarone is up to like 100 days in corneal deposits, whether it is cetalol and ibutylide. Now, the class 4 is calcium channel blockers. That is non-dihydropyridine. Okay, so you can give them in AFib as a rate control therapy. There are two types of calcium channel blockers. Dihydropyridine, that is amlodipine and all, they do not have any effect on the heart. They just lower your BP. But these non-dihydropyridines, they decrease your heart rate. Okay, so I'm talking about the non-dihydropyridine. Now, there's another drug that's called adenosine. I'm going to discuss this one in more detail in SVT. Okay, this is the drug that is exclusively used for SVT. Adenosine. Okay, the contraindication of the adenosine is asthma. You need to ask. And the half-life of adenosine is just 15 to 17 seconds. Okay, I'm going to discuss in detail later on, okay, in the SVT topic. Now, there are anti-general medications. You have the nitrates, like you have heard of NGC, okay, which keeps sublingual. Nitroglycerin, acesulfide, dinitrate, okay, they reduce the preload. Okay, and the side effect of nitrate is headache, intolerance. You need to remember that one. You do not give the nitrates if the systolic BP is less than 90, okay, because they cause the hypertension. And you do not give them with the sildenafil because they're going to lower the BP, okay. Chances of hypertension are very high over here. Then comes calcium channel blockers, dropamine diltiazem, non-dihydropyridine. So decrease the contractility, vasodilation, decrease afterload. So they cause bradycardia. Then comes the beta blocker, atenolol, metoprolol, and bisoprolol. Metoprolol has a half-life of like 6 hours. Bisoprolol has up to 11 hours. That's the longest acting in this group. Again, one that has the longest is nebivolol as well. And nebivolol is highly cardioselective. Okay, nebivolol is highly cardioselective. It's not given over there. So atenolol is also cardioselective. Bisoprolol, metoprolol, these are a lot of cardioselectives. Okay, how they reduce the angina, by the way, like why we give the beta blockers? So your heart receives its blood supply during the diastole, the coronaries, okay, through coronaries during the diastole. So if you're going to decrease the heart rate, the diastole will be more fine during a fast heart rate, definitely during the slow heart rate, because heart will be having enough time to fill it properly. That's why we give the beta blocker. They reduce the heart rate, okay, they reduce the heart rate. So this means that diastole is occurring properly and heart is receiving the blood supply through the coronaries. Then is ivabradine. Okay, that's a new drug, by the way. Not very new, but ivabradine also is a rate controlling agent, and it acts through funny sodium channels. Okay, where you cannot give the beta blocker as a rate controlling therapy, you need to give the ivabradine. Okay, but one thing, make sure when you're giving the ivabradine, okay, there should be the sinus rhythm. You cannot give the ivabradine if the rhythm is not sinus. Need to take care of this thing. Again comes the amiodarone. I have already told you, causes fibrosis, liver, pulmonary. You need to take care of the thyroid function test because it causes the hypo and the hypothyroidism. Hypo or hypothyroidism. Now comes important thing, congenital heart diseases. So they are divided into the two, cyanotic and acyanotic. So what comes under cyanotic? TGA. Okay, I'm going to discuss the important one. TOF, tetralogy of Fallot, tricuspid atresia. Okay, and yeah, these things. The most common cyanotic congenital heart disease is tetralogy of Fallot. Very important MCQ. Okay, but the child is going to present 2 months and onward with the TOF. But in the TGA, that is second most commonest, patient is going to present within days, like maybe at the second day or third day of the life. Okay, transposition of great arteries, because pulmonary arteries, they're rising from left ventricle and aorta is from right ventricle, so totally opposite. So this patient cannot wait for like 2 months. So you need to take care of this thing. If someone's coming to you to the 2 to 3, pick TGA. If it's asked that it's the most commonest cyanotic disease, pick TOF. It's presenting at the 2 months, it's TOF. TGA cannot wait for like 2 to 3 months. It's going to present within 2-3 days. Tetralogy of Fallot, you already know, pulmonary stenosis, right ventricular hypertrophy, overriding aorta, aorta and VST, and you have a boot-shaped heart. Okay, tetralogy of Fallot. These all the things they require surgery. Okay, and then there are other cyanotic, that's persistent truncus arteriosus and Ipsen anomaly. Ipsen anomaly is actually, you need to remember this term, atrialization of right ventricle. Okay, atria, right atria, that is very big and the right ventricle is small. So it seems that, okay, atria has gone into the ventricle. Okay, right atria has gone into right ventricle. That is the atrialization of right ventricle. Here you can see right atria, as compared to that one right ventricle. No, this is right atria. Oh, and this is right ventricle as compared to that one. Very small. So utilization of right ventricle, and that is the lithium used during the pregnancy. Now another is total anomalous pulmonary venous return, when pulmonary veins did run into the right heart. Now comes the aortic heart diseases. So important: VST, AST, PDA. So I have already told you the VST, pansystolic murmur, harsh pansystolic murmur. AST, very important. If you find something like fixed splitting of S2, that is AST. Fixed splitting of the MCQ comes like that. This fixed splitting of S2, that's AST. PDA has continuous machinery murmur. I have already told you. Then comes the aortic contraction, correction of aorta. That is related with Turner syndrome. 15% of the Turner, they are having this correction of aorta. And the second thing they are having is a bicuspid aortic valve. Well, bicuspid means that normally aortic valve has 3 cusps, but here they are having the 2 cusps. Okay, so that's a correction of aorta. Then comes the Eisenmenger syndrome. Eisenmenger syndrome is shunt reversal. Okay, normally, say for example, it is AST, a VST. So left side is high pressure, right side is low pressure. So definitely it's gonna go like this. Okay, because of the pressure difference. Now what happens that, okay, when it happens, okay, for a long time, okay, the pressure is gonna build up over here. Then the back pressure in the right atrium, and there are the lungs as well. So pressure in the lungs develops as well. That causes the pulmonary hypertension. So what happens that eventually the shunt is gonna reverse. Okay, that is called Eisenmenger syndrome. Once the Eisenmenger syndrome develops, okay, there's no treatment. You need to go for heart-lung transplantation because the pulmonary hypertension has developed into the lungs as well, and your heart is already in the state. Heart-lung transplantation. These patients do present with the cyanosis and the clubbing. Cyanosis and the clubbing. And that is a shunt reversal. Initially it was left to right, now it is right to left. Now comes the hypertension. That is important. So the hypertension is when your BP is greater than 140 over 90, or ambulatory BP is 135 or 95. By ambulatory means that our home BP monitoring, that is 135 or 85, greater than. So you need to remember both of them. So this ambulatory or home BP monitoring, that was devised because the people, they used to come to the doctor and they were having something like white coat hypertension. When they see to the doctor, the BP is high, but when they are at the home, the BP is fine. So they have devised the devices which they can measure their blood pressure, okay, attached with them at their home. Okay, so if the clinical BP is greater than 140 or 90, or ambulatory BP or home BP is greater than 135 or 85, that is stage 1 hypertension. If the patient is less than 55, you need to start with the ARBs. By the way, what drugs we are having? We are having AC inhibitors and ARB, we are having the calcium channel blockers, we are having diuretics. These are the 3 drugs. Okay, so in less than 55, you start with AC inhibitors or ARBs. In greater than 55 for Black African or Africo-Caribbean, you need to remember this thing. The MCQ comes like this. Okay, Black African or Africo-Caribbean is given, or sometimes it's greater than 55 only. Okay, so here you start with the calcium channel blocker. If it's not controlled, okay, what's the next step? Add C to A, and here add A to C. And the third step is to add diuretics. This is how it works. Simple as that. The first step you need to remember, less than 55, greater than 55. Less than 55 AC inhibitor or ARB, greater than 55, or even a young patient is Black African or Africo-Caribbean, okay, you need to start with calcium channel blocker. If that's not controlling, just add C to A or A to C. And the third step, that's common, add the diuretics. Okay, but this is not the rule. If someone's coming to me who is having diabetes, okay, who is having diabetes, definitely, okay, even if he is 60 years old. Okay, but the rule is like if someone is greater than 55, start with the calcium channel blocker. But if someone is diabetic, ACE inhibitors are more helpful because they're going to prevent the diabetic nephropathy. So this rule doesn't apply. Go for the ACE inhibitors, okay, or the ARBs, because that's going to prevent the diabetic nephropathy. So exceptions are there. Okay, you need to choose according to. So hypertension and diabetes, first step is AC or ARB. Okay, and second is you need to add calcium channel or the thiazolide diuretics. Okay, so this is important. Normal target is less than 140 or 1 over 90. Under the 80, this is important. Over the 80, it is like less than 150 over 90. Okay. In type 2 diabetes mellitus, it is same as normal clinical BP targets. Okay, that is 130. In diabetes, by the way, it's 130 and 80. In diabetes plus CKD, it's again 130 and 130 over 80. Okay, you need to have a strict glycemic as well as like hypertensive controlling those patients with the diabetes and CKD. So normal, the target is less than 140 over 90. In less than 80, who are not having the diabetes or CKD. Those who are having the diabetes and CKD, it is, you need to further lower the BP. Okay, it's less than 130 over 80. And those who are greater than 80, and this is 150 or 90. You need to remember that's one, they keep on changing. Okay, you need to consult, okay, what are the, if it's something very latest is over there. Now, so important, ACE inhibitors, what they cause? Cough and angioedema. Okay, cough and angioedema. ACE inhibitors are causing because of increased level of bradykinins. Okay, maybe they can ask you this thing as well. So they cause cough, dry cough. So if they started on the ACE inhibitor, patients develop cough, what you need to do, switch to ARB. Okay, switch to ARB. And the other thing is they're called the angioedema. There's a swelling of the lips and the mucosa. You need to stop the ACE inhibitors. And this causes the hyperkalemia as well. Calcium channel blockers, they cause the peripheral edema. Okay, in the clinics, the patient come that I'm having the edema of the lower limb, okay, because I have been started with these medications. So they do cause this thing. Then the thiazide diuretics, they cause hypokalemia. Okay, hyperuricemia. Okay, then there's another MCQ here that's coming into our mind. If you have started a patient on ACE inhibitors, ARBs, okay, valsartan, and he's presenting with the hyperuricemia, all the ARBs, they actually increase the uric acid level, except low sartan, that decreases the uric acid level. So if there's an MCQ like that, somebody is coming to you, I guess, taking the ACE inhibitor and is having high uric acid level and is taking the valsartan, what you going to do? Okay, do not put on other thing, put on the low sartan, because this is the only in this group that lowers your uric acid level. Low sartan, it lowers the uric acid level. Then comes the postural hypertension. So postural hypertension is, okay, when your BP, systolic BP that falls, okay, 20 or greater than 20. Okay, but you are sitting, you're taking your BP, okay, and you make a person stand for 3 minutes. Again, you take the BP in standing position, and if their BP, okay, it falls by 20 mmHg of systolic or greater, that is called postural hypertension. That could be because of a number of reasons, okay, but this scenario says it's because of he's taking a lot of antihypertensive, okay, nolipril, that is ACE inhibitor, okay, and that is causing hypertension. Nolodipine, indapamide, okay, they are causing hypertension because he's using the 3 medications over here, all are causing low BP, so hypertension. So that's why. So multiple antihypertensive, you need to see that one. Now the syncopal episode. An elderly man taking antihypertensive attends the GP after having the 2 attacks of syncope involving the loss of consciousness for a few seconds. He was standing in a garden when he had this thing. His blood pressure was 110/80 mmHg on lying and dropped 25% when he on the standing, and heart rate was 80. What is the single most investigation? Okay, single most investigation. So heart rate, so the blood pressure dropped more than 20 mmHg, what you told. So it's a postural hypertension. So what you're going to do if the patient is having a syncope? By the way, what is a syncope? Syncope is brief, transient loss of consciousness that is followed by spontaneous regain of the consciousness. This is just for a few seconds. Okay, as far as cardiac syncope is concerned, that could be because of some arrhythmias. Okay, the arrhythmia, they are causing the hypertension. Okay, and you drop on the ground. As soon as you fall on the ground, okay, cerebral perfusion, okay, that arrhythmia goes away. Okay, cerebral perfusion is again restored, and you got regain the consciousness. Cardiac syncope is always like for a few seconds. Okay, and you regain the consciousness. So you need to go for the ECG. Say, for example, it says nothing is in the ECG. What you're going to do? Holter monitoring. That is 24-hour ECG. That is Holter monitoring. Because maybe the patient is having an arrhythmia at certain time of the day. So ECG, when you are doing, there's no arrhythmia. How are you going to find that one out? 24-hour ECG. It's going to pick up that arrhythmia. Now comes the severe hypertension. Severe hypertension is when your systolic BP is greater than 180 or your diastolic BP is greater than 120, okay, or higher. That is severe hypertension. Okay, here I will also like to tell you that what is hypertensive urgency or emergency. Hypertensive urgency is that when you are having this much blood pressure, but there is no sign of end organ damage, either clinical or lab. What do I mean by that? If the patient presents with the this BP, okay, with the chest pain, with SOB, okay, that is called, okay, hypertensive emergency. Or if there is like the LFTs or RFTs are deranged, okay, or if you can see the fundi, okay, and there are retinal hemorrhages. So either clinical or the labs with this much high BP, okay, there are clinical signs or the lab indicating the end organ damage, okay, or the fundoscopy. That is called the hypertensive emergency, okay, and you always control the hypertensive emergency with IV medications, IV sodium nitroprusside. If that's they choose that one, you can choose IV labetalol, hydralazine, and there's another medication which is used in the USA, maybe that's available in UK as well. That's enalapril, IV enalapril. That's ACE inhibitor. That's a new one. If the patient presents with such a BP, okay, it's greater than 180, greater than 120, but there are no clinical signs, no chest pain, no SOB, okay, no dizziness, no headache, okay, and you see there are no retinal hemorrhages, okay, and there's no deranged LFTs, okay, RFTs acutely. That is called hypertensive urgency, okay, if the target end organ damage is not there. So you treat hypertensive urgency with the medication, but emergency you need to deal with the IV antibiotics. That could be IV medications, that sodium nitroprusside, labetalol, hydralazine, and enalapril, any one of them. But choose sodium nitroprusside. Okay, it's given over there. So malignant hypertension, then malignant hypertension is that when you have hypertension and you have the eye changes, okay, retinal hemorrhages or papilledema. That's malignant hypertension. So severe hypertension, I have already told you about this thing. Okay. So in hypertensive emergency, you draw up the BP, but to only 25% in first hour. Say, for example, the patient came to you with the 200 of the BP. In the first hour, you do not abruptly drop the BP, okay? You can drop up to 25%. That's like 25% of 200, that's 50. Okay, so there will be 150. Because if you're going to suddenly drop the BP, okay, and try to normalize it like 120 from 220 or 200, that's going to compromise your myocardial perfusion as well as cerebral perfusion, and the patient is prone to the stroke or a myocardial infarction. So this is all of what I have already told you. Do a fundoscopy, and if albumin to creatinine ratio, renal function test, that's all. Now comes the infective endocarditis. Now the infective endocarditis. That's a important topic, by the way. And the thing important over here is that what kind of organisms are involved and what you need to do, and what kind of antibiotics you are going to start. Okay, so infective endocarditis, what are the risk factors? So valvular heart disease, valve replacement, or previous episode, IV drug abusers, prosthetic valves. Okay, that is all. So whenever somebody is coming to you with a fever and a new murmur, okay, always think of infective endocarditis. Patients coming to me with the fever and a new murmur, think of infective endocarditis. Take a blood culture, start with the antibiotics, do an echo. Okay, that is you need to do. Fever plus murmur, infective endocarditis. Okay, so you need to send the blood cultures from 2 different sites. Okay, 3 sets of blood culture, ideally, from 2 different sites. Okay, every set 1 hour apart. Okay, so you're gonna take the blood culture from 2 different sites, then 1 hour apart, again the same thing from 2 different sites, then again from the one, and you need to start the patient on antibiotics. So prophylactic antibiotics, what's given in the UK at the moment is amoxicillin and low-dose gentamicin. Amoxicillin and low-dose gentamicin. If the patient is allergic to, it says that amoxicillin, then choose vancomycin and gentamicin. Okay, that is for the native valve. If it's a prosthetic valve, okay, then choose vancomycin, rifampicin, and gentamicin. Okay, so a new murmur plus a fever, think of PE, take blood culture, okay, give antibiotics, okay, and then do the echo, find out. So it has a due criteria, okay, major criteria, minor criteria, and go through that one. If you have 2 major criteria or 1 major with the 3 minor or 5 minor criteria, and a label decide infective endocarditis. Now, the organisms are important. Organisms are important. This I have already told you, okay? Organisms are important. In a native valve, which organism is common? Native. Native. So it's V in the native. It's very dense. This is important. You need to remember. Very dense. In the native, Streptococcus, very dense. Okay? In drug abuser, A for abuser, okay? Staph aureus. Staph aureus. In prosthetic valve, prosthetic, there comes the E, okay? There is epidermidis. For the first 2 months, epidermidis is most common, okay? That is because you have done the operation, and that because of the contamination, epidermidis. Then, okay, it's aureus again, okay? It's aureus. So you need to remember this thing. In the native, in the themselves.